So okay. Good morning, everyone. Welcome back to 22 Minutes. And today we have with us Dr. David Alleman. Dr. David Alleman, there's so much to tell about him. He's the founder of 6 Lessons to Biomedical Safety. He's been my mentor. And I don't know what to say because 2 years down the line, 2020, I started my mentorship with him. And ever since, it has changed the way I look at the tooth, how I bond my tooth, how I practice. So it has been a great journey with him. And fortunately, we are going to have him in India soon. So, and also looking forward to see you in US. So Dr. David, all over to you today. We share insights from you about your brainchild, the decoupling with time.
Yes, so decoupling with time is a concept that I formulated about 22 years ago. And at that time, I'd been studying the literature on adhesive dentistry for about 5 years. And it became obvious to me that the missing link was understanding the polymerization dynamics of the polymerization reactions. These polymerization reactions are free radical polymerization reactions. And so the polymerization can happen quickly if we have an initiation with light camphorquinone initiators, or it can be more slow if we have a chemical cure initiation with peroxides. But the idea is that these curves of initiation, they go in a very steep rate in the first 5 minutes, and then they start to plateau off after 5 minutes. And then they reach a plateau where they're just polymerizing maybe 2 to 3% over the next 24 hours of the polymerization. So there's a strong polymerization. And every time monomers start to polymerize, there is shrinkage. And the shrinkage means that there is a possibility to having stress in a cavity. But the stress in the cavity is related directly to the number of walls that the polymer is connected to. And the hybrid layer development, which is the key connection between the polymers in the dental bonding system and the restorative composites on top of the dental bonding system, the connection between the actual tooth and these restorative materials is very thin. It's only about 0.5 microns that really connects the tooth. But that 0.5 microns is a molecular connection that is actually very large in the atomic world and the molecular world that teeth are made of. And so by understanding in detail the hybrid layer and how it develops, I was able to deduce that this time frame of 5 to 30 minutes was the key area that the hybrid layer needed to be disconnected or decoupled from the polymers that were on top of it. Now, the hybrid layer, when it's formed, the dental bonding system actually is the polymerization that's happening, but the polymerization of the hybrid layer is not very strongly reacting in the other parts of the hybrid layer. This is because we have collagen, we have moisture. It's kind of a gooey situation for about 5 minutes. And then the polymers that are hydrophilic start to be replaced by the monomers that are hydrophobic. So in the hybrid layer, we have a transition from hydrophilic primers that are being polymerized with hydrophobic monomers that are in the adhesive resin portion of the dental bonding system. And so when we're using these dental bonding systems, and now the next layer, which is the critical layer, has to be kept thin for at least 5 minutes. And the thinness, the science showed us that 2 millimeters was kind of the place where the bulk of the composite or the volume of the composite started to have a negative effect on the developing hybrid layer. And so the rule that my partner Simone Della Pere and I developed in 2008, basically, when we started teaching together, we taught from 2008 to 2018. This was the Alleman Della Pere rule. Once you polymerize your dental bonding system, don't get thicker than 1.5 millimeters with your restorative materials for at least 5 minutes. And that's the decoupling with time basic principle. But during that 5 minutes, what you can do is you can add a layer of flowable to the dental bonding system. And so that takes about 1 minute and 20 seconds, perhaps, to carefully put a 0.5 millimeter of flowable. And then it takes another 20 seconds to polymerize that. So you're in 2 minutes just by adding the resin coating to your dental bonding system. Now, what can you do next? Well, again, you can put another millimeter of restorative materials, because the rule is don't get thicker than 1.5 millimeters. So you've started your decoupling process with your resin coating. And then the next layer of 1 millimeter is placed in at maximum 1 millimeter of thickness. We prepare is actually what we prefer is actually a stress reduction, even of that 1 millimeter, by using increments that are even smaller than 1 millimeter if you have a large cavity. For example, if you had a 4x4x4 pulpal floor, then the increments which would be the most stress reduced and allow the most time to be placed and the most development of the bond strength, the hybrid layer, would be increments that are about 2 millimeters in diameter. A ball of 2 millimeters in diameter, if it's compressed against your resin coating, it might fill up a third of your cavity or a fourth of your cavity to that layer of 1 millimeter of thickness. So you probably would put in 2 to 3, maybe 4 of these small increments, so what we call Della bits, after the inventor of the technique, Simone Della Pere. But if you use 4 Della bits to restore 1 millimeter, it usually takes you about another minute and a half to do that. But the real trick that Simone and I, following the science that was developed from Sema Belli out of Turkey, and her research, which was at her PhD institution, Tokyo Medical and Dental University, she started to place rib-on fiber, which is a polyethylene fiber, woven fiber, that if you place that into that first 1.5 millimeters of composite, it takes another minute to actually adapt it, and then to wet it, and then to polymerize it. And so if you have the resin coating step with polymerization, you have the stress reduced direct composite techniques with polymerization, and you have fiber placement before the polymerization of that 1 millimeter. Anyway, there's 5 steps that if you do those consistently, then that protocol, which we call wallpapering, takes 5 minutes at least. Yes. Sometimes it takes longer. And particularly if you have a wall that needs to be replaced, interproximal wall or a facial or a buccal wall, then those walls are constructed again with the stress reduced incremental technique. And then that will take you maybe 10 minutes to get to 1.5 millimeters thickness on the dentin that's inside what we call the peripheral seal zone, which is the most difficult part of the tooth to bond, because it's more moist. There's more collagen percentage when you get inside of the dentin that's just at the DEJ area, which we call the peripheral seal zone. So these protocols that you've learned and been practicing for 2 years, these become the foundation of every restoration. and the decoupling with resin coating, the decoupling with stress reduced direct technique, the decoupling with fiber placement, and just the time, all of those do the same thing. It allows the hybrid layer to develop without any bulk or volume of composite, which would stress the hybrid layer by moving the composite mass towards the center of mass away from the hybrid layer. So by staying thin, all of the shrinkage moves in one direction. It's called one-dimensional flow. And one-dimensional flow is the key to biomimetic restorative dentistry. And the 6 lessons approach, has been teaching this for 20 years, and we see most of the basically 1 million restorations that have been placed by 400 or 500 doctors that we've trained, lasting more than 20 years, because that's how long they've been performed. If something lasts 20 years without breakdown, then probably it's going to be permanent. Occasionally a biomimetic restoration will have a chip of enamel replacement, whether it's enamel replacement from ceramic or enamel replacement with composite. These materials are brittle, and under occlusal function over decades, we can have some stress and then have some chipping almost exclusively. It's on the distal lingual cusp of a lower second molar. That seems to be the one cusp that gets the most stress in the mouth day in, day out, year in, year out. And we have some fractures there, but the way that these restorations are constructed, the fractures still leave the tooth coated with this resin coating, and that's called the secure bond strategy. The resin coating with the fiber in that first 1.5 millimeters has never been reported to have failed. In other words, there's no redecay, there's no fracture into dentin. Even if you do have a fracture on the enamel replacement, it's easily repaired without numbing the patient up again. So that's the huge difference. If you restore a tooth biomedically, it might be sensitive for a couple of days just from the retraction of the gingiva and maybe some root exposure or just some inflammation of the pulp from the restorative process. But that inflammation is very short term. It never lasts more than 2 to 3 days, and it doesn't come back. And so, the dentists who are listening to us, if you ever have sensitivity that lasts more than 2 days and ever recurs, that means you've not kept your bond and you haven't stayed bonded. So the phrase that we use is get bonded with the protocols of biomimetic restorative dentistry, and then you will stay bonded and patients have a happy life and they can do whatever they want to do besides go to the dentist.
So to avoid post-operative sensitivity, decoupling with time is like absolute necessary. So as we go with the steps, we have done our caries excavation, we've achieved our peripheral seal zone, we've stopped at the central stop zone, we've done our air abrasion, then we give it a really good prime, and then we bond. Now, the question which I get very often is, when does it start? Does it start after the resin coating, or does it start before resin coating, or does it start the time when I've already started applying my prime?
Yeah, it starts before the resin coating. It starts when you polymerize your dental bonding system. So as soon as you put your light on the dental bonding system, the polymerization in that first minute goes to 70% of the polymerization. So in that first minute, you go from 10%, 20%, 30%, 40%, 50%, 60%. Basically, every second, you're gaining a percent of polymerization. And once it's polymerized, then that stress is basically eliminated. And so what usually happens is that a dentist will polymerize their dental bonding system, and then they'll immediately put a 2 millimeter increment of composite, because that's the manufacturer's recommendation. And then they'll put that light on, and in that 20 seconds that it takes to place the composite and start that polymerization, all of a sudden you've had only 20% of the polymerization shrinkage gone. So that means now you have 80% still going to happen. And that 80% will have the ability, if the bulk is that 2 millimeters, to be decreasing the bond strength of the hybrid layer 80%. So you'll go from a potential 50 megapascals to a reality of 11 megapascals. That's what the in vitro testing shows us. But then that complication of loss of bond strength by adding that 2 millimeter composite increment in that first minute, it even is aggravated more when ideal caries removal is not in place or the restoration is deep. If the restoration is deep, then we have, again, another potential loss of 30% of the bond strength based on the more difficult areas to bond that have more moisture and more collagen percentage than the more superficial areas. So there's a direct relationship between the amount of hydroxyapatite that is being engaged with the polymerization and the bond strength. So, we've, you when you went through lesson 4, lesson 1, lesson 2, lesson 3 were preliminary. You have to have a good bonding system, and you have to understand how cracks can undermine the hybrid layer of cracks left into dentin. But the lesson 1, which is the article that is made myself the most famous, Pascal Magny and I wrote that 10 years ago. Using caries detecting dye is not optional in a biomimetic approach, but understanding how caries detecting dye is to be used is only understood after you read that article or an article by the team out of Leuven, Belgium, from Nevis in the same year. And then the same year, a team out of Japan, Momoi, came to the same conclusion. So those 3 papers are really from 3 different research teams around the world, 3 different cultures and continents, and dentists that are still not using caries detecting dye. It just makes everything more difficult, because the problem with the human brain, we want easy ways. And so the easy way is just leave decay or take it out. But the reality is you have to do both and know when to leave decay and when to completely remove decay. And those are presented in that paper that I wrote with Pascal, based on the concepts that I introduced to the profession of using a perio probe. A simple measuring of depth will give you the ability to prevent pulp exposures in the vast majority of situations. And so by measuring the 5 millimeters from the occlusal surface, 3 millimeters interproximally, you're able to prevent almost all of your exposures, even in deep decay and deep crack removal.
There's so many schools of thought, Dr. Alman. Many do not support caries indicator. Many do not support, even the partial excavation. Many say that you should not leave the carious lesion behind. And, so what do we have in support of, why we should do this? Why leaving caries behind? And there's a choice to remineralize should always be there.
Yeah. So what you have to do is you have to read this paper. And then you have to read the 101 references that I put in the paper with Pascal. You have to read them all.
Yes.
And after you read them all, then we can have a conversation. But if somebody isn't knowledgeable of the science, then it's a waste of my time to talk to them, because they think they know something that I know they don't. In other words, if you have 1,000 articles, which is about the number of articles that have been used in the analysis of caries detecting dye, 1,000 articles is a lot. But
Yes.
if you only have to read and master 100 of them, it's still going to take you about 200 hours to actually be scientifically knowledgeable. And so anybody that criticizes caries detecting dye that hasn't put in 200 hours of literature research, it's like, what can I say? They're ignorant. And that's, I hate to say that that's the way the human brain works, but ignorance has caused much worse things than loss of tooth structure over the centuries.
Yes, there are so many different opinions, and I think one has to find their own way of working it out, apply it to their practice, and see what results they get. I think that's a fair way of working out with in these things. So, with this, I have another question, Dr. David, regarding decoupling with time. Now, why do we select just 5 minutes? 5 minutes is a long time when we are on chair. Patient is under rubber
Yeah.
dam. I feel, that urge to just put in the next bit of the composite is like always there in that 5 minutes. So why 5 minutes? Why we emphasize so
Well,
much?
it's based on the chemical equation that shows what the polymerization of. And so all the curves start at 0 and then they go to 100%. And they go steep in the first 5 minutes and then they plateau off. So you get 90 to 95% in the first 5 minutes of the polymerization. So that shrinkage is gone. And then the last 5% is in the next 24 hours. So the reactions actually take 24 hours, but these are called polymerization curves.
Mhm.
And, like I say, hundreds, thousands of these have been published in the literature because every dental bonding system has a polymerization curve that is similar to every flowable composite, that has a polymerization curve that's similar to every restorative composite, that has a polymerization curve to every cementing polymer composite. And so these are basic scientific chemical equations that are understood and documented. And so if you understand a polymerization equation, then you understand what we're saying. If you don't, and of course you haven't learned this in dental school unless you have a PhD in probably dental materials, it's a tragedy. It's not a hard concept to learn. You learned it in, a matter of weeks.
Yes.
You have to, read articles to get to the mastership level that you have. But yeah, it's it's just a shame that dentists aren't taught this in dental school, but that is changing. We have masters that are teaching in probably 15 or 16 dental schools around the world right now. University of Geneva is a good example of leadership there, and other Swiss dental schools have done a good job, and the advances in adhesive dentistry are being noticed more and more in Holland. I'd say those 3 dental schools are doing pretty well. Belgium has had some introduction. And then we have some schools that are outstanding in Brazil and Chile, for example. We have masters that are teaching in dental schools in those 2 countries. So we think India is going to be the next.
Yes, definitely. We are having you in September, and it will be really nice to, we have 40 participants who's coming in for training
Yep.
with you. And I'm sure, but again, I always say, reading papers all to my participants and all over that, I got the understanding once I finished actually reading those papers, and not once,
Yeah.
really.
And it took you how long?
Yeah.
How long did it take you, Disha, to go through the papers?
I took a lot of time. I have seen other participants finish off like really soon, but I think I took around 6 months to just
Yes,
really,
actually,
really,
that's average. And
yeah.
so, we've trained in this mastership program, which we're, training the new leaders and the new teachers around the world. The mastership, the average time to go through the 130 articles that we reference in our protocols, the average time is 6 months.
Yeah.
And some very fast readers do it in 2 months.
Yes.
And others it takes 12 months. It's not the speed, because you're going to have a protocol that you learn. For example, when we teach in Mumbai and we teach in Bangalore, in 2 days every student that we train will have the protocols. They will know what to do.
Yes.
And they will be pretty good at how to do it. What they won't have in 2 days is why the science is telling you what to do. But you can learn the cookbook, and that's what we want. That first level of training in the 6 lessons approach is to, we're giving you a cookbook. This is what to do. and this is how you do it. But then if we really want to feel totally in control of every restorative diagnostic and restorative situation, because every cavity has different dimensions, or all, basically there's no two cavities that are exactly alike. And so to really master that, then it takes more knowledge of these principles that we've talked about with decoupling with time. And the underlying principle of decoupling with time also is on a proprietary concept that we introduce in lesson 1. And one of the reasons why we benefit by using carry sticking dye is because it reveals what's called the hierarchy of bondability. In other words, if we have different areas of our preparation that have more hydroxyapatite than others, or certain areas that have less hydroxyapatite than others, then the polymerization movement will be away from the less mineralized areas and towards the more mineralized areas like enamel and superficial dentin. Yes. And that's exactly what you don't want if you have an area of deep caries that you're leaving to preserve pulp health. And all of the studies over decades, and these go back to 50s and 60s, when partial caries removal, 1965, there's a good paper by Massler out of England that showed it, and many stepwise excavation treatment protocols came from Scandinavia, because if a pulp isn't dead, then it may be sick, but can it heal? It can. In other words, every medical approach is the idea that even if you have infection, the body has mechanisms to overcome the infection and repair the damage. Now, inside the pulp, it's more difficult. It's constricted. But the inflammation, if it's small, can lead to a normal pulp. And these partial excavation or stepwise excavation studies that went into 10 years and 20 years always showed that if you could do a indirect pulp cap instead of exposing the pulp and doing a direct pulp cap, you always had better outcomes. That's even before adhesive dentistry was introduced. And so this idea of partial caries excavation being something that's, it hasn't been investigated is just totally false. And pulps heal every day. And sometimes the dentist doesn't really know what's going on, but the gut feeling that most dentists have is that we don't want to expose a pulp. But if you do that at the expense of leaving caries in the peripheral seal zone, then in adhesive restoration, that will be the first place that will weaken and lose its bond. And that's where the reintroduction of microbes will occur. And so recurrent decay can take that normal 3 to 5 years and even be more susceptible under composite than it was under amalgam because of the antibacterial effects of silver. But the composite adhesives that we have now have antimicrobial benefits like MDPB, the pyridinium bromide, and SE Protect, or an application of chlorhexidine can be bactericidal, kill bacteria. And then all you have to do is keep your bond. But again, those protocols take time. And by learning the protocols, then you can tell your patients that based on clinical trials from hundreds of dentists, we expect these restorations to last decades, not years.
So to say, we already know that enamel is bonding very well. So how to get that good bond to that deep dentine is all about, the whole idea behind the biomimetic, right? So we're trying to get,
correct.
We already accepted that enamel bonds. So that's fine. But how do you get it to dentine, where it comes? Because all problems come there.
So when we talk about decoupling, the main decoupling is the separation of the bond to dentin from the bond to enamel. And so, for example, that resin coating and that first millimeter are not carried on to the enamel. So if you have 2 millimeters of enamel, you would have resin coating up to the DEJ, but not onto the enamel. And then that first millimeter that you create with your Delabits, that would be up to the DEJ, but not onto the enamel. So that first separation or decoupling is from dentin to enamel. But the more tricky decoupling is deep, where you're trying to separate superficial dentin from deep dentin or carious dentin from sound dentin. And so in the decoupling and the hierarchy of bondability that you learn, there's usually 5 to 6 different substrates that you're bonding to in a carious lesion. And so by following the protocol that we mentioned, all the Mandela-Perry rule, that overcomes that hierarchy of bondability by keeping the initial thickness thin enough that there's no adverse effect of pulling the weak areas too soon in its polymerization.
Thank you so much, Dr. David. That was really nice. Great to have you.
All right.
Into
Great 22 minutes. All right. So looking forward to seeing you in a few days, Disha.
Yes, Dr. David will be there.
All right. We'll see you next time. Stay bonded. Bye-bye.
Bye.